Hi there, I'm Laura Barnett, Vice President of External Affairs at Axxess. Welcome to today's webinar, Compliance Made Simple, Leveraging Hope for Success. During our 55 minutes together today, the webinar questions feature will be available. We plan to answer any questions that you may have at the end of our time today. Early next week, every registrant will receive a link to today's recording along with the slides as well as some additional resources. It is now my pleasure to welcome our panelists to today's webinar. First, Rosena Clarke-Turner. Rosena has more than 20 years of expertise in post-acute care with time spent as a surveyor. We're really grateful that she can put on that surveyor hat today and help us better prepare for what surveyors are going to look for after HOPE takes effect. I'd also like to welcome Amy Rose. Amy is the Senior Product Director for Hospice and Palliative Care Solution Delivery at Axxess. Prior to joining Axxess, Amy gained extensive hospice and palliative care experience at the agency level. She is also a registered nurse. We're now something like 35 days away from the start of HOPE. So it's really vital that we share a bit more about HOPE as a concept so that we're all on the same page. And so for that, I'd like to turn things over to Raianne Melton, Axxess' Senior Director of Clinical Services for our Professional Services team. Raianne?
Thank you, Laura. Well, we like to begin these webinars by just level setting the, information to make sure that we're all on the same page as we talk about HOPE. And, with a focus on compliance today, really thinking about what are the things that we really need to be thinking about as administrators, clinical directors, and even as a staff nurse. I think that these are the highlights that I want you to keep in mind. Number one, there is going to be the non-compliance penalty for meeting less than 90% of records submitted to CMS within the 30-day time window. So, nobody wants to be hit with that 4% decrease. But I have to tell you, in looking at the hospice final rule, it's so, I think that so many agencies are now being hit with that 4% penalty that CMS, in the final rule, they published not only the rates for the regular rate, but the rate with the minus 4%. So, really be thinking about this because we're all working on very limited margins financially. So, making sure that you have processes in place to meet those deadlines for the admission for all of the visits, admission, HOPE update visits, and discharge is going to be essential to avoid that penalty. Something else that is going to be new to us is that the HOPE assessment is for all patients admitted to hospice. There's no longer any exceptions for age or payer. So this is a paradigm shift for us, and we really need to keep that in mind. Another compliance issue that is going to be, I think it's confusing in the way CMS wrote it. They never asked me before they publish something to see what I think. And, I've been 20 years into this and they're still not calling me up and asking me what I think about things. But I will tell you that the admission timeline is it says 0 to 5 days, with 0 being the day, this day 0 being counted as the date of election. Now, the way I was raised in hospice, guys, as a hospice admission nurse, is I always did my initial comprehensive assessment on the day of election. That's just the way it worked in my organizations. So if you look at that, with day 0 being the date of election and the date of the comprehensive assessment, when you count that, and you use all your fingers, it's really going to be 6 fingers. Yeah. I guess I should do it this way on the camera. I don't know, 6 fingers that you'll have to count before you're into the HOPE update visit window. And, so being, just cognizant of that and making sure that you understand that nuance, I think is going to be very, very important. And I think that, truly, thinking that and no understanding, understanding that when a hope update visit is going to be required and when it's not in relationship to discharge. Because if a patient is discharged during the hope update visit window, one of the hope update visit windows, it's not, that hope update visit is not required for submission. Best practice, I think, is to get them done early, get them done well, get them done early, so that there's no chance that you're going to be out of compliance. But I know that Rosena and Amy are going to talk a lot about this because they're really very, very smart about this stuff. And I think I think those are my highlights on where we're at in regards to hope.
Wonderful. Thank you. I appreciate that. And this may be because I just finished lunch, but if we're looking at the rest of today kind of like a meal, I feel like us having Rosena here is sort of getting to eat dessert first, because this is so special to have her expertise, that putting that surveyor hat on and being able to delve into her understanding, her knowledge. We get to look through that surveyor's lens at what the hope change means and what you, as a hospice operator or clinician, need to do so that you're going to be breathing a little bit easier, or hopefully really easy, when the surveyor is at your door. So Raianne, thanks for kind of level setting for us. But Rosena, I'm going to shift over to you. What is the most important thing that people need to keep top of mind when a surveyor shows up after hope takes effect in October?
Thank you for the question, Laura. Part of what we really have to understand is that CMS state and the deemed surveyors, they're going to continue to verify for the very same things that they always checked on when they come into your organization. They're still going to be looking to see that you provide effective pain and symptom management, that you respect the patient's rights and choices, that you develop a care plan that is sensitive to the patient and their family, okay? They're going to continue to review all of those things that they always did, looking at accuracy in your documentation, your staff qualifications, and on day one, they're still going to be doing that. But in addition to those things, they're going to be checking to see that hope is just not a data collection tool, but rather that it's an integral part of enhancing your assessment, that it's personalizing the care plan based on what you're finding, that you're ensuring timely symptom management, and that you're continuously improving the quality of hospice services. That's what hope is going to do. So while agencies need to focus on what the surveyor may think, just understand that in preparing your staff for workflows and the documentation that's going to be necessary will help you to be survey ready, because the surveyors are going to look for the patient assessment and care planning. Is it timely? Is it a thorough assessment? Is the hope data integrated into your care plan? They're going to be wanting to see what's happening with your interdisciplinary team collaboration related to symptom management and symptom follow-up, and changes in that care plan that reflect what you're now documenting. Well, I'm not going to say what you're now documenting, what they can now see in your documentation. And that's a very important paradigm shift that I want us to understand. The other thing that they're going to be looking for is that symptom management and follow-up. Timely, and is it timely? Is it appropriate? And have you documented what you needed to do to show some efforts to intervene on patient suffering? Opioid management and bioregime has always been a significant part of hospice-related care and managing symptoms. That's not going to go away. And I'm going to say, and finally, there are two other areas. The compliance that Raianne talked about, and I'm sure Amy will expound on, in terms of the hope data submission. Proper use of iKeys is one of the things you need to be aware of as well, okay, for how that, what's happening with your data. You're looking at the final validations report. They will have access to that information when they walk in your door, okay? And so you need to have it as well. And then they want to look for documentation for patient exclusion. When you cannot comply with hope, for whatever reason is legitimate, make sure that you're doing that documentation. There's a reason why we have 90% instead of 100% compliance, because there are mitigating circumstances. You just need to document to it to stay in compliance. And then finally, surveyors will still be looking at your overall quality of your care and your QAPI programming to see how you're making those adjustments for your overall management of patients based on your data trend and that analysis that you are finding from the documentation. They're looking for data-driven quality improvement based on how you're collecting HOPE data and how you're tracking the key performance indicators. A lot of things are not much is changing. They're just going to incorporate your alignment of HOPE, the conditions of participation that are related to HOPE in your overall operational and clinical functioning. A long, big mouthful.
It is, but tons of wonderful knowledge. Thank you for sharing that. And one thread I want to pull through that is new is that symptom follow-up visit. As you probably know by now, if a patient says that they are experiencing a symptom and they're rating it as moderate or severe, HOPE is now changing so that that recording of that symptom at moderate or severe is now going to trigger a follow-up visit to ensure that that symptom is being managed appropriately. So in the what does that mean for me section, that means hospices are going to have to add in another visit to check on that patient. And it's within 48 hours, which from a patient care perspective makes perfect sense. But from a scheduling perspective, may kind of throw a wrench in things. That may be, and some folks may see that's an additional burden for me. We already know, I don't have to tell anybody this. We know staffing is a challenge. So folks may look at this as a burden. They may look at this as a problem. Rosena, do you think there is a risk that hospices may try to skirt that moderate or severe documentation so that they're not going to trigger that from occurring? And, does that kind of take shape in any way for you?
I love that you've summarized the perception that CMS is now ordering frequency for patient care. Because that is very much, they have not seen the patient. They will not see the patient except for what it is that we document. But it is a very common perception that CMS is saying you have to do another visit. CMS is not directing frequency. CMS is saying, give us the data that shows that you're responsive to your patient's need in end-of-life care. So amidst CMS's concerns about threat of fraud and beneficiaries not getting the care that they needed, CMS is saying, give me the middle of your data for end-of-life care. Mm-hmm. What I really want to believe is that care is already occurring. I don't believe that there's a hospice nurse on the face of this earth who's going to experience a patient with a pain or non-pain symptom that's moderate or severe and is going to walk out of there and in 2 days or more not respond to what that patient is needing. So really, in reality, CMS is missing some data. And the reporting of care that is provided to avoid patient suffering is what CMS needs to get the full story. The data extraction from that symptom follow-up visit is what's going to be that reportable data to CMS to say, we're doing what we need to do. I bet you, if you look in your policy and procedure manual right now, there's a process for timely management of symptoms. There is one. And with best practices, we've already been doing post-unresolved symptom follow-up visits. They're already being done. Tuck-in visits, we talked about that before the weekend, all those things that hospices have been doing forever. CMS just doesn't have that detail. So clinicians should only have to rely, and I think I'm going to set you up for this, Amy, on this electronic medical record, extrapolating that data to communicate to CMS that those processes are already in place. I don't believe that nurses are going to downplay patient symptoms because we haven't done it before. We've just never had to report it. Mm. So hopefully there's not going to be any behavior change regarding the scheduling of encounters for patients, and CMS is not going to have to start writing frequencies to manage patient symptoms because this is already being done. We just will have better ways to record our assessments and our interventions and have our electronic medical records extrapolate that data to give them some idea of a sample of what's happening in the middle of care. CMS wants data from the care points to tell the middle of the story. Just show us the quality of care that is sensitive to the patient's beneficiary needs. And that's what we're being asked to do. I'm going to ask two quick questions, and then I'm done with this one. Thank you for the question, Laura. I'm so glad you asked. But have you wondered why CMS has not asked for symptom follow-up visit data points throughout the hospice benefit period? It'll be too many to report. In that, there's no expectation for symptom follow-up visits to continue after the first 30 days. No, they're just not reportable. And with that, I'm going to shush.
That's great perspective. I appreciate it. I have one more question for you before we turn things over to Amy. And this kind of, I guess, is sort of a bit of a pullback question. So what is CMS saying you're going to need to do differently from a clinical and from a reporting perspective? Obviously, as you're talking about this with symptom follow-up, the care is already being provided. We're just going to sort of make it official now. Are there any other changes that folks are going to need to watch out for?
There are going to be so many of them, but they're doable. The biggest thing is going to be, in order for us to show CMS what, and I'm not saying that we need to change to impress them, but we need to document quickly, because late documentation will be our Achilles heel. Because if that RN visit, that admission doesn't come in for 5 days, and a moderate or severe symptom was indicated, there is no way to be compliant with what is necessary. So that's going to be, I think, part of our biggest challenge, is doing things in a way that is timely to be able to capture and report to CMS all that is necessary.
Right. Laura, before we move over to Amy, I would caution, having worked at a lot of smaller hospices, where rural hospices, where staffing, the workforce is really an issue, and you've been doing telehealth visits for that symptom follow-up visit. Yes. That is going to be, you're going to have to figure out. And, as we know, it's so much easier to, make a telephone call or, do that telehealth visit. But knowing that this needs to be an in-person visit within 2 calendar days, I think it's going to be a challenge for many smaller hospices. So if that's your current practice, you really need to be thinking about how you're going to be able to manage those in-person visits.
That's a great.
And Raianne, to follow up on that as well, if you're not accustomed to having that RN in there every 14 days, that will be another change, because that HUV visit cannot be done by an LVN. Yeah. So that's a big change as well that you may have to make.
Great perspectives all around. Rosena, thank you so much. And Raianne, thanks for chiming in. Amy, you've been waiting so patiently, and you have been focused on hope for more than a year. You've eaten and slept and breathed it forever. We've talked about this for months. Today, really, the focus is on the specificity around compliance. And I want to start talking about the documentation, because that's such a huge component of this. What can users expect from Axxess Hospice in terms of this update and how they're going to be interacting with the software?
Yeah, I think the biggest thing is, I've said it before and I will continue to say it. When we first started looking at HOPE and the HOPE questions and the questions that CMS wanted responded to from a HOPE perspective, myself and so many other clinicians that I talked to said, well, this is just stuff we're doing already anyways. So at admission, they added, I believe, like 5 or 6 new questions. There are questions about living arrangements. Of course, we want to know about our living arrangements for our patients and what kind of level of service that those living arrangements are providing. I thought that particular question from CMS was like, I really like the way that they framed that. I think that would have elevated my assessment at the bedside, in the sense of really making me be thoughtful about actually answering that question, to go, oh, I might have a risk here of them, as they decline, not having a caregiver that's available. I've kind of gone down a rabbit hole there, but as we go through the other questions, is death imminent? Of course, as a hospice nurse, every time I'm going into a patient's home or assessing a patient, I'm assessing whether I believe they're imminent or not. Was I always documenting if that answer was a no? Not necessarily, right? I wouldn't necessarily have said I assessed and they aren't imminent, but still, that's just a thing that you do inherently and naturally as a hospice nurse, is to ensure, okay, this patient is not making this transition into a more imminent perspective. So, other questions are integumentary questions, so your skin assessments. So essentially, and I could kind of go on and on about this, and then as you go into the HUV time period, and again, with your symptom follow-up visit, we've talked a lot about that. But let me pull back really quick and really answer the root of your question, which is, what can you expect in documentation? And really, our approach was very much in alignment with the feedback that, well, this is just care. This is just routine care. So one of the big things that we said is, why do they have to be unique independent visits that then increase burden on clinicians? Because Raianne, you started to really drive into this concept earlier as well. What if I miscalculate my days? I can tell you I'm a lot of things. I'm a great nurse, but it's not my job to calculate what day of care the patient is in. That is not a thing I ever want to have to worry about at the bedside. I have so many bigger things to worry about. What I really want to worry about is that the patient is getting great care and that I'm walking alongside that patient. I know as a hospice nurse, I have to see my patient every 14 days minimum. Okay, so if I have to see my patient at admission, which, to your point, Raianne, 99% of the time your initial and comprehensive is being done at the day of, day 0, day of election. And then I have to see my patient between days 6 and 15. Well, yeah, I'm probably going to be seeing a patient between days 6 and 15 as a good hospice nurse, and they just came on services, probably even a little bit more frequently than that. And then I have to see my patient between days 16 and 30. Well, if you don't see them in that window of time, you're just straight non-compliant. So why would we want additional visits? Why not just have these questions be available and baked into all of my nursing assessments, which give me an opportunity to really not have to worry too much about compliance. All I have to worry about is good documentation as a nurse. And so, of course, we wanted to bake in some support items that really allow the clinician to have some control of what, because I don't remember if it was Raianne or Rosena that said it, but CMS can't dictate the needs of our patients. Only we can do that. And so our good assessment and our documentation of that, and sometimes it doesn't make sense. And sometimes you will need a missed visit for your symptom follow-up visit, because if you call them up and you say, hey, I'm going to need to come and see you, and they say, nope, not today, I don't want that, you have to honor that. And that is something that CMS has given us an opportunity to consume through the data. So, really, I would say what clinicians can expect from the documentation is that it is their routine documentation that they are used to today. They just need to be on high alert when they get messages, when they get notifications, when they have required fields, which that's pretty hard to miss because you can't close your visit without that. We will help them guide through and ensuring that they're going to get a symptom follow-up visit done. And that's what good technology should do for a clinician, is just really help them focus on the patient and not have to worry about, did I schedule the right visit?
Right. How did we approach the other compliance tools that we've built into Axxess Hospice?
Because always there are other compliance needs, right?
Course.
Because the clinician is only one factor. To Rosena's point, if clinicians aren't documenting timely, all of that, there is absolutely an opportunity. Even still, we could build the perfect system and there's still an opportunity for a clinician to miss an HUB visit, because it's just the way that dynamic patient care goes and the way that the chips fall with timelines. And that doesn't mean we're giving poor care. But one of the things that we have done is really create a report that has a lot of visibility into HUVs and SFDs. So do you have one scheduled? If one is scheduled, has it been done? Do you not have one scheduled at all? That's a risk as well, right? Additionally, we've created some support items to really be able to view data across your patient population. So again, how many of my patients have SFVs that are due that aren't done yet? How close are they to the end of their window? And then I just want to bring up Z0350 just a little bit. So Z0350 is an item at the end of every assessment that needs to be submitted to CMS. Z0350 is the date that you are going to be responsible for submitting your records to CMS for within 30 days. So what is that date? Especially when you're looking at an HUV window of time where you potentially have 2 visits, right? You have your visit that's capturing your initial HUV data. And then if that's requiring an SFV, you have a second visit somewhere in that. Is that second visit that same day? Is it the next day? Is it 2 days from your initial visit? That required that SFV. Whatever your last visit is in that time frame is Z0350. So whoever's processing his records today, this is a very brand new concept. And as we talk about the 4% reduction, there is risk there in the sense that if you're individuals who are processing HOPE records, especially if you're a large organization or a small, or any organization has this risk, but I see large and small as these potential because large has volume and small has the person that processes HOPE records probably does 10 other things as well. And so you have risk in the sense that if you don't know when that timeline starts to count down for you to submit that record to CMS in a timely manner, there's a compliance risk there, and you can do all the things that you should have done to document, but if you didn't submit the record to CMS timely, it doesn't matter.
Yeah. What I'm hearing from you is you have answered this call to provide hospice care, to walk through this really difficult, really tender season of life. And you're answering that call. And so your focus needs to be lasered in on who that patient is, what their goals are. Are they experiencing pain? Are we treating that effectively? What family support is available? And everything else kind of falls away, but that really needs to fall away into your technology. And you need to focus. I mean, the technology cannot provide the care for the patient, but the technology can do all that additional wraparound that allows you and empowers you to focus on answering that call and doing that job to the best of your ability.
Absolutely. That was the vision.
Wonderful. Let's kind of broaden this out into a bit of a panel conversation. Shift in, you had mentioned HISS, Amy, and really we know that this shift is really monumental. What did surveyors see? What did CMS see as major compliance issues with HISS? And what do you anticipate changing to HOPE is going to result in terms of compliance issues?
It's a really thoughtful question. You want to take that first, Rosena?
All of the issues that are related to timeliness, and Raianne, you talked a little bit about this before, and I know you've mentioned it if you had problems with HIFs, you can have problems with HOPE. That's the bottom line. Because what are we doing? What we talked about, we're introducing more volume to the process. We have more data points to submit. The responsibility is not just to have those assessments completed timely, and I will always make this distinction. There's a difference between that when that assessment needs to be completed for the admission and for the other time points, as well as when they need to be submitted. So don't mistake the completion date of an assessment for the submission date. 30 days from completion is for submission. You still have to comply with the completion date for the various time points in the patient's care. So that's important. If you have made mistakes in terms of being able to access keys and iKeys for the correct FAC ID and identifying that information in your software, those are potential problems as well. The other issue is that if you're not accustomed to looking at your final validation report to be able to tell whether or not those reports that you've submitted have been accepted or if they need modification, or they need to be inactivated, and you didn't do anything about it because you thought that pressing some button in the solution automatically uploaded things to keys, you can have a similar challenge with iKeys. So it's extremely important that you develop work protocols now for how you're going to manage the approval of your Hope data so that that is timely, so that you can accommodate for the volume shift that's going to occur, and that you're submitting things where they're supposed to go, and they're not sitting somewhere floating in cyberspace because they have not connected with, if they didn't connect with keys, they're not going to connect with ITs. But making sure that you have already identified, and we talked a bit about this on our last webinar, that you have your security official who is already in keys, who has aligned your PTAN with your FAC ID in keys, and then your other users are available for their HAP. They've gone through HARP, and they already have their user IDs and their passwords that's going to allow them to transmit things timely. Lots of words again, and I'm trying to shorten them. But those are the realities. If you had trouble with HIS, you're going to have problems with keys, and we're anticipating that because you do what you need to do. Now, the other thing that Medicare has said is that, please, by September 10th, have that security official identified so that you don't have delays, because everybody's doing it at the last minute for being able to access iKeys for your data uploads.
Good reminder.
Amy.
Thank you.
Yes.
Go ahead.
Back to you, Amy.
Well, and I was actually going to prompt Raianne. Raianne has a really fascinating perspective on what she feels that CMS may do with the Hope data and how that may inform payment going forward. And I really love the way that she frames it. So if I can put you on the spot, Raianne.
Oh, okay. So, Jennifer Kennedy from CHAP eloquently says that hospice is the caboose of the home health trade. And that really is true. And where home health is right now is in the first year of payment adjustment based on 3 factors. One is OASIS-based information data that is in its key items that CMS has picked out. Claims-based data, which is all around hospitalization and rehospitalization, and home health CAHPS surveys. And, putting on my gypsy wardrobe and getting out my crystal ball, what I predict is that by 2032, maybe even between 2030 and 2035, we're going to be facing the same thing. Mm-hmm. And what we're going to be looking at is a similar package where it's going to be Hope-based items. It's going to be claims data pulled from the Hospice Care Index, which will be burdensome transitions and live discharge information. And then, of course, the CAHPS hospice survey. And this is and if they do what they did in home health, after they evaluate the information, your agency will be subject to between a +5 per Medicare episode reimbursement to a -5 adjustment in payment for that reimbursement using a bell curve. So, if we look towards that, I think that, that is what we should be focusing on in terms of how we look at Hope. And thank you for teeing me up, Amy, but I want to tee you up on timely documentation. I say it all the time. The way I was raised in hospice was my documentation had to be done by the end of the day. And, it was, and that was the rule. Mm-hmm. I later down the road, I took a gig as an interim hospice executive director at a small rural hospice. And I had nurses who did not complete their documentation until the end of the month regardless of when they did the visit, just to get it so it'd be ready for billing. I mean, that was frankly shocking to me, but that, Amy, take it from here. Timely documentation. Finishing your documentation on time is going to be a
truly so important and so interesting, because I grew up in the same kind of hospice realm that you did, Raianne. It just was simply unacceptable if your visit was still open after 24 hours, now closing that visit within 24 hours. And so it is a little bit amazing to me that there are still so many practices where, visits aren't being closed timely. But the reality is, and I really think about symptom follow-up and how important, especially symptom follow-up, is in timely documentation. If I am sitting and caring for a patient and I, assess maybe they are just an absolute mess, they really need, maybe even we're looking at a higher level of care or whatever it might be. And so of course, I'm going to see that patient the next day, right? And so that data is probably going to be available for me to just go ahead and suffice that SFE in the next couple of days. But what my worry is the patient that's just a little bit on the cusp, right? I'm like, oh, okay, shortness of breath is a little bit of a problem. It is affecting them. I'm going to go ahead and assess that it's at a 2. I'm going to order some medications along with, I'm going to advocate with my physician, order the medications, get them out. And then maybe my standard practice would have been give the patient a call in the next couple of days. How is that new medication going? You're doing so much better. I'm so glad. So to your point, Raianne, telehealth visits are definitely a risk here, because CMS doesn't necessarily give us an out for, well, I did it telehealth and not in person. So that is the risk, where if I didn't close that visit timely and I'm either a new Hope nurse, I just haven't gotten my sea legs under me, or maybe I really haven't understood the Hope framework, and that visit should have required an SFE. If you're not if you're not closing your visit, if you're not putting that documentation into the system, it's not going to show up on reports. It's not going to show up for you to notify. And so that timely piece really becomes important when we're talking about a 48-hour requirement, because 48 hours will go by in no time. And to Rosena's point, if you called the patient, if you did the right thing, if you cared for them, all of that needs to be documented, but you may still not get that green check mark from a compliance perspective or from a Hope compliance perspective. But certainly, I'm not saying you didn't take good care of the patient, but that all could have been avoided had you had your documentation in timely.
And if I can add to Amy, what you're saying is that really it's going to increase the need for your QA staff to be vigilant, because your trend analysis is going to show whether or not that's a trend that's occurring if you're assessing on the lower end, but you're still needing to do so. And you've lost that window of opportunity to capture it appropriately to show your quality care. So your QA staff who are looking at it, if the surveyors could catch it, your QA staff could catch it also. So watch your trend analysis, watch your clinician practices regarding what you're having to see when patients are close to that level of moderate or severe, and looking at those interventions. That's part of what your QAPI program will really help you to highlight, so that you can map out for overall better high quality care.
Mm-hmm. Such great perspective, Rosena. Thanks for chiming in. We know that, and there are some folks that absolutely love compliance, and God love them for doing so, because that's not everybody's favorite thing. I think a fair number of folks can say, yeah, that's drudgery, that's work, right? We've built some components into the solution that we're really hoping will not only, feel more pleasant, but really delight people. Can you talk about some of those, Amy?
Yeah, I mean, for me, again, you could probably sense how at my core, I was like, I am not going to be calculating patient days. As a nurse, I am not doing that. So really having a visibility of where that patient is in the timeline, I think, is really important. Kind of just seeing it spelled out for you. Here are the dates. Here's when it starts. Here's when it ends. And to me, that's kind of one of the most delightful features. We also have like a really cool dashboard that shows like if an HUV has been done, that symptom assessment was done during that HUV period, and then the symptom follow-up visit accordingly. And, if it's not required, it clearly shows it's not required. So it's really a nice tool that helps you track the patient throughout that first 30 days of care. We already had a lot of this built into the system, but of course we have a lot of connectivity into our interdisciplinary care group center. And I think Rosena talked a little bit about IDG earlier and how to leverage IDG and to make sure that your full team is on the same page and that we're talking about symptoms in a really meaningful way during IDG. And we can really just continue to frame that question around IDG in the sense of, well, did we get our SFD done? Do we have a concern for HUV2? Are they going to need an SFE and HUV2? Just really kind of start to pre-plan some of those things that we already know are going to be probably required, and how as a team are we going to handle that, both from a staffing and a care perspective. So we have a lot of ability to communicate some of those things into the IDG Center. I always feel like that's always super delightful. And then I do feel like we have done a great job in supporting those individuals whose workloads are going to double and triple, who are processing his records today. They've gone from having one record to process in the first 5 days of care to 3 records to process in the first 30 days of care. And that can just be an enormous jump. So how do we make that experience more streamlined? Rosena had talked earlier about, when you have oddities like modifications and inactivations of records, we really worked hard at the beginning of this year before we even started coding on Hope to make that experience better, because we knew it would lay a better foundation for the volume that we would be seeing as we walked down this Hope path. So tried to be really thoughtful about all of those aspects.
Awesome. Thank you. I'm going to ask this of each of you, and I'll probably chip in with mine first. So what is one takeaway from today's conversation that you want to ensure our audience knows? And I think something that Rosena said really stuck out to me, which was, if you have problems with HIS, you'll have problems with Hope. And as we know, that longstanding phrase, the best predictor of future behavior is past behavior. And so if that was a burden, if that was something that was a challenge for you, now is the time to start planning to put those processes in place to adjust your habits so that you are documenting it in a way that is more timely and ensuring that that's completed so that you're going to get credit for the work that you've done. Raianne, I'll start with you. What's one takeaway that you hope folks leave with today?
There's so many good ones, but I'm going to say timely documentation completion and visit frequency. I don't really think we talk a lot about visit frequency, but you can't have the RN going out once in 2 weeks, once in 14 days, guys. You're really going to have to be very thoughtful. If nothing else, I think the behaviors that we're going to have to change in the first 30 days of care are going to really drive better patient outcomes and caregiver satisfaction for longer lengths of stay in hospice. So you're going to, these habits that we're going to have to develop in those first 30 days are really going to be to everyone's benefit, your staff's benefits, your business's benefits, and most importantly, the people we care for, the patients.
Excellent. Thank you. Rosena?
She gave hers already, right?
Provide the care as if you were the QA nurse who was giving the seal of approval to the caregiver who served your parents, and let it be a relative that you really liked. Okay.
I love it. I love it.
When my Pollyanna soul takes over. And really, I submit to you that I am hopeful, full of hope. And that's, the pun is intentional.
Right.
That as an industry, we'll embrace this opportunity to be caught doing not just good, but greater than expected with restricted resources. I want the CMS to come out of this saying, we're not paying them enough. Okay. See Hope as the minimum standard required for excellence in end-of-life care. Don't fear the minimal standard, or don't fear this change.
Mm-hmm.
Define them as the most basic representation of our excellence that our organizations provide, and showcase the patient-centered care that is being provided and the intensity of your operations that Medicare needs to see so that they can reimburse us differently. Okay? I'm going to say exceed the minimum standards that are represented by HOPE. All of this is about my takeaway is these are minimum standards, because we can identify what we're already doing that supersedes these standards. No nurse is going to wait 2 days to go follow up on a patient. Medicare says SFV in 2 days. We're going to show them we do it in 24 hours. Minimum standard is 2 days. Utilize the existing resources that we already have and utilize them strategically. We already have on-call nursing positions. Utilize them for the follow-up visits that need to be done. Okay? Consider HOPE as the opportunity to reform how care management occurs at the end of life, prioritizing for your best practices, and revision of your practices and your protocols if you in fact need to do that. One of the things that I had an opportunity to do is look real briefly at what's the frequency of organizations, what frequency do they utilize in the first 30 days. In 95% of the review that we did, there was at least one visit every week in those first 30 days. So some practices are already in place. Let's supersede those. Okay. And this one I'm going to go with. Remember when end-stage renal disease became a thing that Medicare covered? What happened? How did that happen? Those dialysis nurses took those washboard-looking dialysis machines on the floor of the Senate and showed the senators what needed to happen when people had end-stage renal disease. Dialysis is covered under Medicare. This is an opportunity for us in hospice to really show what is really occurring in terms of the quality of care that's occurring at the end of life. We have AI and care documentation that already will decrease the documentation time so that we can spend time providing direct patient care. We have automated ways in which Amy just talked about, we could trace the symptoms and trend indicators, and so that they can be utilized by IDG and then be sent to CMS. Let us inform Medicare that HOPE equals minimum standard by the high quality of care that we provide.
Amy, that's going to be a tough.
Have you standing ovation? I can't go after that.
I've been to
All right,
church.
my one takeaway.
In the church.
Right? My one takeaway I would say is really leverage your IDG in the next coming, we've got 4 weeks almost until HOPE. So you have at least 2 IDGs, hopefully more if you're on a like every other week cadence kind of thing, or 2 teams cadence. So in that IDG, if you're a person that is in any way responsible for being an IDG, and even if you're not, go join the IDG anyways and kind of take an assessment of the kinds of conversations that we're talking about, in particular with the patients that are newly admitted, and their symptoms and what their frequencies are and how that would potentially fit in. I've really encouraged a lot of organizations do case studies in your IDGs, get in, dig in, act like, okay, if this was HOPE, how would we be maybe answering these questions? Would we need a follow-up visit? Would our frequency have met the need for HOPE? Really take advantage of digging in from that, doing a little mock survey, I would say, in your IDG over the next couple weeks.
I love it. Great idea. Thank you. We are almost at the end of our time today, but we have 2 questions. So I'm going to pose those to you ladies. Crystal has asked, and Amy, this is probably going to be for you, so I'm going to set you up for this. Do you have plans to leverage notifications to alert when a clinician has an outstanding visit that needs to be completed? It may be a good idea to have something pop up to remind them of outstanding visits so that we can address timeliness of documentation and the impact it could have on improving and submitting assessments to IEPs.
Yes, we do already have a baked in notification that is built with the processing of the Hope record. Obviously, it will tell you, hey, your clinician hasn't closed their documentation. It won't let you process that record until it's closed. And so that's a pretty hard stop. And then we have several reports that are already available that show you visits that are not closed. The SFE HUV report that we've created is one of those that will tell you if you have a visit, but that visit's not been closed yet. So lots of different opportunities there.
And I'm going to keep you in the hot seat because Bobby has a question and asks, will Axxess have an option to schedule HUVs and FSVs, or will those auto-populate based on the admission note?
So it will need to be scheduled by the clinician because all care needs to be driven by the necessity of the patient. So
it's perfect sense. Excellent. Thank you, ladies. I appreciate your time today. I appreciate your wisdom. And Rosena, thanks for the spiritual uplift. We all, I think, are better for it. Thank you all so much for joining us today. We appreciate you spending a part of your day with us. And as we mentioned at the top, we will be sending out a link and some additional resources early next week. So we hope that you guys are getting ready for Hope and will hit the ground running come October 1st. So have a fantastic day.
Thanks, everybody.
Thank you.
Thank you for joining Axxess On Demand. Visit axxess.com for more on-demand videos, industry resources, blogs, and answers to frequently asked questions. Axxess, empowering care anytime, anywhere.